Can micafungin at 150 milligrams per day reach concentrations high enough in the urine to treat a Candida glabrata urinary tract infection? The answer is not reliably. But, and this is the critical nuance, the answer may be different when the infection is located inside the kidney tissue, such as a renal parenchymal abscess. The key is to stop thinking of Candida in the urinary tract as one single infection. A bladder infection, an ascending pyelonephritis, a fungus ball, and a hematogenous kidney abscess are different anatomical and pharmacokinetic problems. Micafungin is an echinocandin. It is highly protein-bound and has minimal excretion of microbiologically active drug into the urine. IDSA specifically states that echinocandins do not achieve therapeutic concentrations in the urine and are generally ineffective for Candida urinary tract infections. So, does increasing the micafungin dose from 100 to 150 milligrams solve the problem? Probably not. Micafungin demonstrates approximately linear systemic pharmacokinetics, meaning that a higher dose increases systemic exposure. But there is no robust clinical evidence showing that 150 milligrams daily reliably converts micafungin into a urine-active antifungal. Now, there are some interesting and frequently cited clinical observations. A small prospective study measured urinary micafungin exposure in only 6 patients with Candida urinary tract infections. 5 of the 6 patients achieved the investigators' proposed urinary pharmacokinetic target, and the patients were successfully treated. But this was a 6-patient study, not a randomized trial. The urinary concentrations were variable, and the study does not establish that every patient receiving 100 or even 150 milligrams will achieve adequate urinary exposure. A separate retrospective study evaluated 33 hospitalized patients with candiduria treated with micafungin and reported frequent short and long-term urine sterilization. Several small case series have also described successful treatment of Candida glabrata candiduria. These reports prove that micafungin can sometimes work. They do not prove that it works reliably, or that urinary eradication necessarily represents successful treatment of a true invasive urinary infection rather than removal of a catheter, resolution of colonization, or treatment of renal tissue disease. For symptomatic cystitis caused by fluconazole-resistant Candida glabrata, the IDSA recommended treatments are amphotericin B deoxycholate at 0.3 to 0.6 milligrams per kilogram daily for 1 to 7 days, or oral flucytosine at 25 milligrams per kilogram 4 times daily for 7 to 10 days. For ascending pyelonephritis caused by fluconazole-resistant Candida glabrata, IDSA recommends amphotericin B deoxycholate with or without flucytosine, or, in selected situations, flucytosine monotherapy. And remember, liposomal amphotericin B is not equivalent to amphotericin B deoxycholate for a urinary infection. The lipid formulations do not achieve adequate urinary concentrations and should not be used when activity inside the urine is required. But now let's move from the urine to the renal parenchyma. A kidney abscess, particularly one produced through hematogenous dissemination, is a tissue infection, and micafungin may achieve useful concentrations inside kidney tissue even though very little active drug appears in the urine. IDSA specifically states that infection localized within the kidney, as occurs with hematogenous spread, can probably be treated with an echinocandin because renal tissue concentrations are adequate despite inadequate urinary concentrations. So, for a true renal parenchymal abscess caused by an echinocandin-susceptible Candida glabrata, micafungin may be a rational option. However, notice the language used by the guideline, probably. The evidence is based primarily on pharmacology, animal data, and limited clinical experience, not high-quality comparative trials. And there is no convincing evidence establishing that 150 milligrams daily is specifically superior to 100 milligrams daily for a renal Candida abscess. There is another major complication. A renal abscess may communicate with the collecting system. The patient may simultaneously have candiduria, obstruction, an infected stent, a nephrostomy tube, or a Candida fungus ball. In that mixed situation, adequate kidney tissue exposure may not be enough. Imaging is essential to identify hydronephrosis, abscess formation, emphysematous infection or fungus balls. IDSA emphasizes eliminating urinary obstruction and considering removal or replacement of nephrostomy tubes and ureteral stents. And if there is a fungus ball, antifungal therapy alone may fail because the obstructing fungal mass often requires surgical or endoscopic removal. Conclusion. So here is the bottom line. Micafungin 150 mg daily does not reliably achieve adequate urinary concentrations for Candida glabrata cystitis or an ascending, urine-dependent infection. Increasing the dose may increase systemic exposure, but it does not eliminate the fundamental urinary pharmacokinetic limitation. However, for a true renal parenchymal infection or hematogenous kidney abscess, micafungin may be reasonable because kidney tissue concentrations are substantially better than urinary concentrations. Before choosing therapy, determine exactly where the infection is located. Is it in the bladder, the collecting system, the renal tissue, or is there an obstructing fungus ball or abscess requiring drainage? Because with Candida urinary infections, you should not simply treat the organism. You must treat the anatomical compartment.